Hi, it's Dr. Centeno, and today we're going to do something a little different. I'm going to be trying to get you to tell me what topics you'd like to see featured on this show. So usually what I'll do is I'll come in and I'll spend 5 to 10 minutes giving a small lecture about a certain topic. And those are the topics that I'm interested in trying to find out from you what it is you want to hear. The hard part about all this is sometimes it's pretty easy to tell based on back and forth discussions with patients what some of the hot topics are. And other times it's a little bit more difficult to divine that. So that's what we're going to focus on today. Obviously, I'm also here to answer any questions that you have. So it's not just focusing on that. And let me go and just share my screen here. And we'll put this up. So again, focus right now is trying to get as much as I can from you with regard to the kind of hot topics that you want to see. Okay, so again, trying to source new hot topics for Facebook Live, and that's what we're doing today. So we'll start with Dan Semrad. Dan runs the Picl group. Let's see. Given the recent unfortunate case of a patient coming down with COVID right before the procedure, what's your view on Moderna's bivalent booster vaccine? Is supposed to provide coverage for Omicron subvariants BA4 and BA5. Good idea, or skip it? That's a tough one to answer. I think my biggest concern with the vaccine right now is only that it seems to prompt a fairly significant inflammatory response, systemic inflammatory response in the patient. So for instance, I recall the last booster I got, feeling every little part and parcel of my body that's ever been injured right after the booster for about 24 hours or so, a little bit less. So that's my only concern, is that some of our patients have a hard time controlling systemic inflammation. And so I'd probably, if you're going to get a booster, I'd give it a week or two before you come in and get a PICL procedure. Now, obviously we do have patients, and it's pretty rare, I think it's only happened once or twice, that are scheduled for a PICL procedure, and obviously they're feeling sick, they go get tested, they come back positive, and then they've got to quarantine for that 5 days. So I'm not quite sure there's a way to change that. Obviously, since we're seeing bigger community spread of COVID right now, some of the things you can try to do might be to isolate a little bit before you come out. That might reduce that risk. Obviously, you can go ahead and get boosted. Those are other things to do to reduce the risk. But I don't think that'll ever be zero, in the same way that obviously any medical procedure could be canceled and or obviously trips get canceled, et cetera, these days. Hi, Dr. C. My C56 is desiccated, a new MRI showing pinched nerves. My Look Regenexx team is upcoming. How does Regenexx franchise treat 5-6 pinched nerves? Well, if it's a pinched nerve, usually the way that we'll treat it is a platelet lysate injection around the irritated nerve, and then usually to tighten down the ligaments at that level, because it's usually a degenerative level, and or treat some of the muscle atrophy. So that's generally the DDD procedure approach to treating that kind of problem, it's usually pretty successful. I would say about 7 to 8 out of 10 patients respond really well to that. Submitted in advance by Sarah. Does PICL help the case of pathological CXA? Has he seen evidence of this helping, not helping, both in imaging and symptom-wise? I think he's possibly talked to this, but it's been a while. Yeah, so I think we all need to understand what CCI means, right? CCI means craniocervical instability. So there is no such thing as a static number like a clavoaxial angle that can give us all that much information about instability. So I think that's the thing that's getting confused there a little bit. Let me see if I can pull up just some information on CXA, so we're all talking about the same thing here. Okay, this is actually our picture here, so let me go ahead and share that. Okay, so this is the clivoaxial angle. So it's the angle basically between the skull and the dens here. And a low clivoaxial angle would be 130, 135 or less. A high clivoaxial angle, generally 150, 155 or more. So a low clivoaxial angle means that your head is forward. A high clivoaxial angle means your head is backwards relative to your spine. Now, this is just a single measurement that's not at all focused on any motion. So it doesn't really say a lot about instability, and it's CCI, or craniocervical instability. So the bigger issue would not be, can we change anything that has anything to do with this clivoaxial angle, but can we change the instability or reduce the instability that this could indicate, but by itself doesn't indicate. So it's important to realize that our focus is trying to reduce instability, and the clivoaxial angle might be helpful in trying to get some clues as to whether or not someone is unstable, but by itself, it doesn't mean a lot. Regenexx, submitted in advance by Liam. I'd like to know if positive response to traction has any bearing on potential of symptom improvement following PICL. I'm assuming that you mean, Liam, invasive traction, and I have not seen it have any bearing on outcome at this point that I have seen. Lindsay, 10 days out from PRP with Dr. Schultz. Your clinic amazing, came from Oklahoma. Normal to still have increase in symptoms this early on. Yeah, Lindsay, I always tell patients that depending on who they are, so average patient, meaning someone doesn't have CCI, no other big problems, who walks through the door, would be sore for 3 to 7 days after a procedure like this. Now, for CCI patients, that could be 3 days to 3 weeks. So still within the realm of normal. Robin Hay, does desiccated C5-6 lead to problems down the road? Surgery. I have zero pain upon palpation, tingling, numbness in hands, though. Not so much, Robin. The focus here is going to be on trying to reduce the nerve irritation and to stabilize that level. So we're not really talking about long-term problems with a desiccated C5-6, but it may need to be treated. Submitted advance by Oleg. I've been wanting to ask for a while. I'm not sure if I'll be there live today, but definitely watch video after. As always, I've read that some people actually get worse from the injection therapies, clarification long-term, aside from initial recovery period. What percentage of that, what seem to be the main factors in causing this, correlating to it, what's actually going structurally, where's the damage, of what nature? So Oleg, I'm not quite sure which injection therapies you're talking about, but if we're talking about craniocervical instability patients, that's pretty rare. I'd say we're talking about 1 or 2 patients in 800. However, as far as long-term flare-ups lasting anywhere from 3 to 6 months, I would say that's happening in fewer than 5% of our patients, and probably less than that. So that's the best I can say there. Not at all a common thing. But again, it's also important to realize there is no such thing as any medical procedure. Doesn't matter what it is, even something like this that's relatively minimally invasive. Anything can make any patient have increased symptoms. So always important to understand that. Submitted advance by Corinne. My question is regards to high ICP. My pre-atlas adjustment CSF flow study showed evidence of increased pressure, in addition to obvious right IJV compression, but the only symptom I had was slight headache upon awakening that quickly resolved after sitting up. The AO adjustment now is C1 in place, but I now suspect a bilateral compression because 24/7 head pressure, blurry vision. Yeah, Corinne, so a couple of things to understand there. You can't measure ICP on a CSF flow study. So those two things can't go together. There's just no way to get from here to there. Now, as far as IJV compression, that could be potentially a problem, but just realize that it's probably important to read about that and understand it a little better. So let's pull up that information here. And if we go, I wrote a blog about that not too long ago. So IJV, hopefully it'll come up under that. So this is a good blog for you to read here. It goes through these concepts of the internal jugular vein sitting right in front of the transverse process of C1. Now, the problem with IJV compression as a concept is we have to be careful with that because there's an awful lot of people walking around that have IJV compression and don't know it. So let's look at this part here. I'm going to try to make it bigger because this is what the research says. And I think it's important for all patients to understand this. So this is a study here where they just took normal patients who were going in for another type of imaging study who were not there at all for anything having to do with IJV compression. So they wanted to try to determine the normal rate of stenosis in these patients who didn't have any symptoms of IJV stenosis. So moderate stenosis was seen in about a third to 1 in 4 internal jugular veins, right versus left there. Severe stenosis was seen in 1 in 4 patients, and approximately 1 in 5 to 6 patients right versus left. And severe bilateral stenosis, which would be the worst possible category, was seen in 1 in 10. So we have to be really, really careful when we're talking about these things and theorizing that they may now be causing our headaches, etc. It's equally possible that the AO chiropractor has the wrong vector for you and is causing issues that way. But very important to be a little careful when we talk about IJV compression causing symptoms, because there's a lot of normal IJV compression out there. It's been advanced by Laurie. How to know how to proceed when DMX and MRI are conflicting reports? One says CCI, the other does not. What do patients do when they don't have both positive? Yeah, so Laurie, I think we have to be careful about what we're talking about here. Remember, instability is a movement-based concept. So a DMX is a movement-based study. So we're more likely to see CCI if it's present when we're looking at a digital motion X-ray, because a digital motion X-ray is a moving study. Hence the M, right? Digital motion X-ray. Now, the average MRI is not a moving study. And even if we have a moving MRI, in my experience, it's not going to be as sensitive as DMX. So there shouldn't really be any conflict there, meaning a DMX is more likely to show instability when it's present, meaning it's got higher sensitivity, is what we say in medicine. An MRI would have lower sensitivity for looking at or for detecting instability if it's there. So that's probably what you're talking about there. And it's critical to understand the difference between those two studies. Chiropractic biophysics. How does this complement PICL, posterior PRP? When best to schedule around regenexx procedure? Any case studies worth highlighting? Yeah, I think for CBP, so CB, chiropractic biophysics. So let's look that one up. Oops. Okay, let's see, idealspine.com. So if you're looking for a CBP provider, this is a good website, idealspine.com. Now, here's the thing. Most of our PICL patients won't tolerate this until we get them much more stable. So you have to be careful and work with your doctor, because he should be able to tell you, hey, I think you're ready to try CBP. Now, what I always tell patients is if you really just want to do your own check at home to see if this is an appropriate thing to try at this juncture in your recovery process, or depending on how much instability you have, then a good way to do that is just to take a towel, roll up a small hand towel. You can experiment with how thick that is, put it behind your neck here, and lie face up. Your goal is to increase the curve in your neck. Now, there's going to be two possibilities there, right? One is you're going to be like, wow, that's amazing. That feels really good. I like that. Another possibility, obviously, is I don't really notice much difference. But another possibility that's concerning is, wow, that really flares me up. If it really flares you up, you're probably not ready for CBP. If you're one of the other two categories, you may be, but talk to the doctor that's working with you. Peter, yes, live. Thank you for adding that. Maybe you could do a series across multiple live chats about each type of regen. One day PRP, another stem cell. Sure, yeah, that'd be great, Peter. I think we'll add that to our list there. I know that we've got Carol watching, so Carol, if you can take some notes on that and try to, we can do certainly one on PRP, we can do one on bone marrow stem cells, we can do one on culture expand stem cells, and kind of compare and contrast all those different things and try to jump into those things and dive into them a little deeper. Connor, if the thoracic spine is stuck in extension, is this likely to be muscular? And could it be that thoracic, in my case, is flattening to overworking to hold the head? You know, Connor, I'm not quite sure what you mean by stuck in extension. I think what you may be seeing is changes in posture related to what's happening in the head and neck, but I'd probably need to look at all that stuff, for instance, standing x-rays, things like that, to be sure. It's been advanced by Harry Winston. I'd love to hear more discussion about how to protect your neck and daily activities, especially strenuous workouts to prevent CCI. Sure, Harry, we can go ahead and add that to the list. Carol, if you can add that to our list, that'd be great. Or each live chat could start with a review of interesting relevant research or medical literature. And Peter, that's kind of what we've been doing. So we'll certainly keep that approach. Daniel, I have CCI and wonder why my head gets heavy after a few hours upright. It isn't heavy the first hour upright. Yeah, Daniel, so that's a great question. Basically, we see all the time in CCI patients that the upper neck muscles start to atrophy. And I think they're atrophying in this case primarily because they can't keep up with the demand placed on them by the unstable ligaments in the craniocervical junction that are causing the CCI. So that would make sense. Your muscles are being asked to do something that really were never designed in the first place to do, which is to provide all the stability because the ligaments aren't doing their job. So that makes sense. And obviously after an hour or two of trying to do something that they weren't designed to do, they just sort of give out. Regenexx, submitted in advance by Carlisle Sherman. My suggestion is a discussion of EDS and tips for preventing injuries, how to treat them when they happen. Sure, Carlisle. Great topic. We'll get that on our list. Carol will add that to our topic list. Levon, would having an upright MRI and CSF flow to Dr. Rosa serve as an auxiliary when it comes to PICL and posterior, i.e. such imaging will result in better understanding of structure, therefore more precise treatment? You know, we love the work that Dr. Rosa does. He does amazing work in trying to really get very specific about which things are injured. So we'd want to see, number one, a digital motion x-ray, which is our standard. And then if we have additionally some great work by Dr. Rosa that says, hey, you may want to look at this, this, and this structure, that's usually very, very helpful. Kristen, I've jarred my neck going around a curve in the car in which my neck was in bad alignment due to poor adjustment. Have patients still seen healing after re-injury at 3 months. I had stopped having dizzy symptoms a month, a little before PICL, and now they're back. Yeah, Kristen, we still, depending on whether or not you've got EDS, I don't recall, but if you do, yes, we still could see continued improvements in that 3 to 6 month time frame. Normally, we don't even look until the 4 month time frame, so you're still kind of right in there. Era Heiderson, I wanted to ask if there are specific ways to measure mast cells and or mast cell activation syndrome. You know, Era, not my area of expertise, so I'd probably get more with a functional medicine doc on that one. HRH, since you just did a quick test to see if CBP is tolerable, towel test, is there an at-home test to when AO is tolerable post-PICL? You know, I really don't have one for that, just because that's such a very specific vector-driven type adjustment. And every person's vectors are different. Kristen, my upper back seems to be pulling on my neck when it cracks in and out. Would it be wise to treat this next round? Yeah, Kristen, we always want to try, if the patient can tolerate it, to treat as much of the issue as possible. So there are a lot of PICL patients where we treat SI joints, for example, or where we treat the low back, or we treat issues in the upper back and rib cage. So that's usually a good idea. Connor, you said the muscles atrophy in the upper cervical junction with the instability. Does this concept apply to the rest of the spine? If it's unstable, yes. You got to realize that, you know, let's say you were going to start training for a marathon, right? We've all heard of overtraining. And overtraining would be, let's say you really hadn't run very much, and all of a sudden you're put into this situation where they make you run 40 miles a day. For the vast majority of us, we're probably going to just fail in that situation. We're not going to get stronger because it's such a huge demand relative to our capabilities. Now, there are some people that would get through that and they'd be stronger, but most of us wouldn't be. It's the same thing here. We're asking muscles to do the work of ligaments, and when they're doing the work of ligaments, they're just not able to do that. Okay, so other questions, anything else I can answer? Any other topics you guys can suggest for other shows? That would be great. You know, literally, if you've just got stuff on your mind, type it on down there, and I'm happy to try to answer anything I can. Or if you've got a topic to let me know about that you'd really love to see covered on this show, please put that in there as well. Again, today we're sourcing topics we're really just trying to make sure that the information I'm presenting here once or twice a week is stuff you want to hear about and stuff that's interesting to you. Sometimes it's easy for me to figure that out, sometimes not so easy. So it'd be great to hear if you've got any thing that you can suggest there. And or any other questions, I'm happy to answer if you have those as well. And just to update everybody, I did look at the first draft of the newest PICL research today. Good news is still working well for the average patient. So we're seeing all of the what we call PROMs, which are really just outcome measures, patient-reported outcome measures that are headed in the right direction. Now the next step there is I gave my team some directives to start pulling in the EDS versus non-EDS parts of that, and then to pull my data together with Dr. Schultz's data, because we were looking at initially both of those data sets and then just my data. So that's well on its way. They're doing a great job. They're going to get us there to answer some important questions like how EDS versus non-EDS responds. And hopefully here we'll have that information for you in the next month or so. But I did see that they're working hard on this, that they have gone through and cleaned up all the data and gotten it all nice and tidy and starting to put it together. So that is happening. HRH, can you do a ligament healing curve, strength versus time for PICL? Sure. I think that's a suggestion for the show. So Carol, if you can write that down, that's really just going to be looking at the phases of ligament healing and trying to superimpose that upon what we see for PICL treatments. Carrie, love to have you discuss when you have and have not, or when you need to have a knee replacement. Definitely do that one as well. CCI and insomnia, definitely do that one. That's a good one. Connor Edwards, in my case, I have so much instability widespread across my body. Alongside the CCI, it makes exercise intolerable, but laying around, making the muscles waste quicker is very complex. And that's another whole nother set of issues as well, Connor, that are very real. I'm going to try to, or actually, I had gotten some topic ideas from Dan Semrad, so I'll add those to our list. He had put it in the PICL group, so I'm going to add those to our list as topics to do. It's been advanced by Jeff Sinsky. My suggestion is a comparison of the recovery of regenexx procedures versus surgery for the same issue. Sure, we could look at doing that. Maybe suggest some specific surgeries, given that there's about 100 surgical procedures that we replace here at regenexx. So that's maybe give me your top 5 list that you'd like to see, something like that. Any other questions I can answer? Any other suggestions for topics for this show? Just let me know. Again, to just go through that again, if you didn't hear it the first time, did see the first round of the new PICL data and the PROMs, patient-reported outcome measures, still continue to look great. So we're still seeing those sorts of general improvement amongst everybody in the data set. One of the questions we wanted to answer this time, now that we have enough data to answer that, is whether or not there's a difference between EDS and patients without EDS. And I gave my team some directives today to start wrangling in that piece of it. So we should have that for you here shortly. Connor, now Dr. Kirkor isn't treating in the UK. I think what Connor is referring to specifically is he's not doing upper cervical posterior work. And that gets back to what we've talked about many times on this show before, and that is that upper cervical facet injections are an extreme niche within interventional spine. And there are very, very few physicians that have enough experience in that area to feel really comfortable doing those procedures. So for example, in all of Europe, there might be 1 or 2 physicians who have done that, let's say a 0-1 facet injection under X-ray guidance, more than 50 or 100 times. So obviously not a lot of experience, and that's their entire career. In the United States, we might have 10 or 20 physicians who have done that more than 100 times, but not much more. And again, very little experience. Obviously, very different at our clinic. We've done that 2,000 times, just myself. then Dr. Schultz would add to that. So obviously a different gig there. Barbara, how long after PICL should you wait before getting a COVID booster? I'd wait until that initial inflammatory response is completely done with. And so I'd give it a good 3 to 4 weeks, maybe even as many as 6 to 8 weeks, simply because you want the inflammatory phase to be completely done and that initial tissue to be completely laid down. And then it's going to slowly reorganize over time. So I'd give it, let's say, 6 to 8 weeks before you had a COVID booster in there. Daniel, how much improvement do the patients see? Like 20, 30, 60%? Not quite sure what the question is. If we're talking about objective changes in things like C1, C2 overhang, I think as I've reported before, we're generally looking at 20 to 30%, sometimes more or less improvement with each procedure. If we're talking about patient-reported symptoms, again, somewhere between 20 and 50%, I think is pretty reasonable from the first 2 procedures. And where the person ends up has a lot to do with how severely they were disabled to begin with. Kesley, topic, CCI and its effects on the CNS. Yep, good one. Kesley, we'll add that to our list. I think that's a really good one. Sherry, after having stem cells in knees, doing PT, how can I strengthen my knees? Is walking enough? I struggle with stairs. Yeah, so I think, Sherry, the focus should be in physical therapy, strengthening the quads, strengthening the hamstrings, gluteal muscles or butt muscles. And a physical therapist can help you with that. If you're looking for, try to find the best physical therapist in the country consistently, I would search this. This is a group I found a long time ago, and they're really some of the consistently the best physical therapists that I can find. Now, the hard part for me is that obviously there may be superstars in every single specific part of the country, but if I'm trying to find a national list that I can trust and say, if they've been through this program, which is intensely education-based, these guys are super duper high level, this is a great place to look to try to find those physical therapists that take their game kind of to the next level. So Sherry, this would be a good place to go or look for a therapist. HRH, how long should you use a cervical collar post-PICL? HRH, I generally don't recommend starting a cervical collar after a PICL treatment because it's a two-edged sword. On the one hand, it could help with healing. On the other hand, it's going to make the muscles weaker. So we don't generally do that. Now, if someone's already on a collar, then they should just continue doing what they normally do, with the goal being weaning off of that collar. But I don't recommend a special collar after PICL. Anya, how is it decided that muscles need to be injected? Is it decided because the person has pain or atrophy should be visible on scans? Yeah, generally, if it's either one, that we can identify pain in that muscle or that muscle tendon, or if someone has atrophy on scans. That's generally how that works. Phil, I've had 2 posterior PRP injections, C012345 by Dr. Kirkor, 60% better after 3.5 months. Great to hear, Phil. Dr. Kirkor doubts long-term benefits for EDS patients, whereas a trauma-induced CCI like mine is seeing more positive results. Hence, I hope he changes his mind, as I found AlgoCellus to be extremely professional. Yeah, Phil, I think AlgoCellus is a great site. That's one of the reasons I was recommending them to my European patients. However, I think, again, you got to realize how much of a niche injection 01 and 1-2 is, even if you're highly trained in interventional spine. So I think that's the issue that we're seeing there, is that not having the experience of doing that thousands of times, it can get pretty daunting for any provider. So I don't know if Dr. Kirker is going to change his mind about injecting the high upper cervical spine or not. I can tell you that we do it all day, every day, and it's just it's pretty routine for us. But we're probably the only clinic on earth where injecting 01 is routine, meaning that I'm not sure you could find a clinic in Europe or in North America where you could walk in and talk to the spine doctor who's highly trained in interventional spine and say, is injecting 01 routine for you? And the answer you're going to get back is, hell no, it's not routine at all. So that's the problem. Kelly, I'm joining late, so sorry. Did you answer the question? Can CCI cause intracranial hypertension? If so, we'll re-listen to the live once over. Yeah, Kelly, I think what I pointed to was this blog on IJV. So if you go to the regenexx site, the main regenexx site, and you just type in IJV, internal jugular vein, this article comes up. What is intracranial hypertension? What does it have to do with the neck? That goes through all of that stuff and just talks about how that might work and goes over some anatomy and talks about how instability can affect all of that and what the main IJV compression symptoms were in the research, and then how often IJV is found in normal people with no problems at all. So that's a really good one for you to read. Connor, now the UK isn't doing posteriors anymore, and I'm sure where the next closest place is, I want to try posteriors first. Yeah, I think the closest place is going to be here in the US. I don't know how to give you that answer any better, or at least the closest place with extensive experience in doing that. Okay, guys, any other questions I can answer today? Again, today was about just trying to source some really good topics for you guys. And I've had some great suggestions, so thank you. In the meantime, any other questions I can answer here, I'll be happy to do so. Otherwise, we'll start wrapping it up for the day. Kelly, my doctor doesn't think it's vascular IH because the IJV didn't show as compressed in imaging. He thinks it's all spinal fluid. Sure, but the big question would be why, right? Why is that happening? And also, getting to that diagnosis isn't trivial, meaning the only real way to get to that diagnosis is to float a catheter up intradural to the right area and measure that pressure. It can't be measured on MRI. It can't be measured during a routine spinal tap. So that's the hard part, is that very few centers really have the experience enough to do that where that's routine. I've seen a few of the larger academic medical centers do it, but for the most part, that's not how patients are getting that diagnosis. Anya, Dr. Centeno recently posted a video talking about a doctor injecting 02 facets. Can you ask if that doctor is from the US or Europe? That was C1, C2, and that's a US doctor. And it wasn't actually the doctor that was doing it. It was the doctor's assistant that was doing that procedure. So they were, so the doctor wasn't doing it, but the doctor's physician's assistant, i.e. not a doctor, i.e. half the training of a doctor, was the one doing the procedure. So that's why it was super duper scary. And then there were some problems in how the procedure was being done, but that's a US clinic. Doug, thank you, Doug. Topic, CCI and comorbidity with other diagnoses. Sure, HRS, we'll add that to the list. Gotcha, he's wanting to go head first in Diamox and a tap. Well, since Diamox is much less invasive, that's not a bad thing to try. It's used all the time for altitude sickness. It's a relatively innocuous drug. As far as a spinal tap is concerned, that's really not going to give us much information. Again, The only way to get information about whether or not there's intracranial hypertension up here is to float a catheter from all the way down there up in here and measure that pressure. If he's not going to do that, and there's a 99.9% chance he won't have the expertise to do that, because that would be an X-ray guided procedure like an interventional cardiology procedure, then a spinal tap is probably not going to give that kind of information. Now, it may give other kinds of information that he's trying to rule in or out. So there may be other reasons for doing that, but it's probably not going to be that. Okay, guys, any other questions I can answer today? Okay, so we'll start wrapping this up for the day. Today's topic was about trying to get more topics, and I've gotten some great ones, so we'll add those to the list and I'll start looking at them. I believe I'll be doing this on Friday. So Friday will be, I'll be here doing this, hopefully with one of those great topics you guys suggested. And I want to thank you for your time today. Have a wonderful day and a wonderful week. And I will see you on Friday. Thank you.